Assalamu alaikum. I'm going to dive straight into my subject. It's almost an aphorism amongst rheumatologists that rheumatoid arthritis is a disease that needs to be treated early and needs to be treated aggressively. So that's the principal message of this talk, but how early is early, which is part of the theme I'm going to develop for you. I want to dive, as I say, straight into the subject, and the notion that aggressive and early treatment derives from a number of studies, including the one which I quote here, which involved a comparison between a number of combinations against a single monotherapy approach using sulfasalazine. I'm not going to discuss the results in any detail, except to come to the conclusion, which seemed to suggest that if you use combination, you're more likely to have better preservation of the X-rays of affected joints at a year and beyond. But at the end of the study, those improvements seem to have been maintained over the following years as well. And from this study has developed the idea that we have a window of opportunity in the early years of rheumatoid arthritis, and if we neglect it, we're doing a disservice to patients. Now, not all the studies which have looked at early rheumatoid arthritis have been able to demonstrate this effect. Nevertheless, it's caught hold of our imaginations, and this is the message today: early recognition, early treatment, aggressive treatment, and you are affecting the outcome long term. I have to tell you now that the evidence base for that premise is weak, and it's encompassed in the slides that you've just seen. Nevertheless, I think it makes sense to recognize this disease early. And how early is early? Well, I think that in my own unit and in other parts of the UK, we're taking this a little too seriously and looking hard for the identification of patients who might develop rheumatoid arthritis. But it's long been recognized that before you get arthritis, there may be a prodrome of fatigue and stiffness and other clues. And it's certainly true that the presence of rheumatoid factor and anti-citrulated C protein, which is a bit more specific for rheumatoid arthritis than the rheumatoid factor, may be raised for years before the development of symptoms. So there may be some evidence of the disease well before the classical features evolve. So what, you may say, should we be forever searching for patients who may develop rheumatoid arthritis, and even if we do identify such people, should they be treated, even aggressively? Well, it is a point for discussion. These are data which illustrate the point I'm making about rheumatoid factor being present long before the disease becomes apparent. And this is a population study from Sweden which illustrates how rheumatoid arthritis may develop amongst people whose rheumatoid factor was identified 18, 13, 15 years beforehand. And the same is true of citrulated C protein, CCP, and that's registered on this slide too. So it's an interesting phenomenon. It also has practical implications because, you know, sometimes people stumble upon a positive rheumatoid factor. They may do it for inappropriate reasons. Certainly in my own country, general practitioners will often ask for a rheumatoid factor even when the symptoms do not suggest rheumatoid arthritis, and having found a positive test, they wonder what they can do with it. And a proportion of those patients will develop rheumatoid arthritis. If you look at these data, but it may take a decade or more before they do so. And the same is true of the acute phase response. Both ESR and CRP may be elevated years in advance of the development of symptoms of rheumatoid arthritis. So if you truly believe in searching for people who are going to evolve into rheumatoid arthritis, the clues are there. So should we be doing that? Should we be screening for rheumatoid factor? Remember that rheumatoid arthritis affects 1%, 1 in 100 of all populations around the world. So you can make an economic case for screening. I'm not suggesting we do, but the cost effectiveness of such an approach is being seriously considered in the UK. But as I say, if you do identify people who seem to have risk factors, we do it for coronary artery disease, risk factors of rheumatoid disease, what then? It's hardly justifiable to expose them to the risks of the disease-modifying drugs that I'll make some reference to. And as I say, we mustn't take this argument to extremes. I mean, how early do we mean by very early rheumatoid arthritis? Certainly not in infancy. There are other problems. In rheumatoid arthritis, are we talking about one disease with a lot of different causes, or is it several diseases with one cause? In other words, rheumatoid arthritis, as we recognize it and define it, has a number of ways of presenting, and the patterns don't always conform to one image. And in 40% of people, there may be no rheumatoid factor at all. That may identify another disease, or it may simply be a subset. So a lot of unknown questions about this common disease. There have been attempts to try and define very early rheumatoid arthritis, and here is one. And these clinical features will be familiar to all rheumatologists. So joint pain, which is persistent, stiffness, very characteristic feature of all inflammatory diseases, someone with pain in more than 3 joints. The symmetry of rheumatoid arthritis is actually a relative late feature. It's always mentioned as a feature, but